Dr. Malwinder Sandhu, who will be speaking on the latest advancements in prostate cancer. Dr. Malwinder Singh earned his Bachelor of Medicine and Bachelor of Surgery from Malacca Manipal Medical College in 2006. He completed his Masters of Clinical Oncology from UCM Malaya in 2015. Dr. Malwinder has specialized training in stereotactic radiotherapy at the prestigious Tata Memorial Hospital, Mumbai, and refined his expertise in gamma knife radiosurgery at now Homose Hospital, I'm sorry I mispronounced that, in Czech Republic. His clinical practice is centered around advanced treatments, including gamma knife radiosurgery for brain tumors and SBRT for prostate and lung cancers. He has a special interest in breast, colon, lung, prostate, and brain cancers, and is dedicated to providing cutting-edge, patient-centered care. Let's give Dr. Malwinder a warm round of applause.
Okay, good morning, everyone. Thank you for a kind introduction, and thank you for inviting me for the talk. So my topic for today will be latest advancement in prostate cancer. So things have changed in oncology much, where those days most of the patients will actually just do chemo and surgery, whereas now we have much more newer treatments where the patient do not need to go through a lot of toxicity. Okay, so yes, I work in Patai Hospital, Kuala Lumpur. So my goal for today is actually for you all to understand the newly diagnostic tool, Transforming Patients' Care, and then a review of the most recent update for localized and advanced prostate cancer, and also be familiar with the future directions in clinical research for prostate cancer. Okay, so prostate cancer is the third most common solid malignancy in Malaysia actually. It happens in more than 50 years old. Family history, especially first degree, especially when we just found out about BRCA mutation, and also if ethnicity is more towards the African ancestry. Okay, this is from our local National Cancer Registry database. Okay, so the first diagnostic advancement, those days when we have prostate cancer, we rely on CT scan and then bone scan, and then we came in with MRI. But something new is multi-parametric MRI, where like for breast cancer, when you send a patient to do your mammogram, you get a BIRAT scoring. You see whether you're BIRAT 1 to BIRAT 6. So now for MRI prostate also, we can actually do a PIRAT scoring to see what is the score system. So if it's a very low scoring, so it's high chance it's actually not cancer. But if it's a higher score, then it's chances that it's cancer, where you need to go for further biopsy. So you do not need to straightaway just subject a patient to 12-core needle biopsy of the prostate before doing an MRI. So if MRI shows that it's something not significant, you do not need to go for a biopsy also. You can just monitor. And then next thing in the market now is actually PSMA PET. Most of our clinical trials for prostate cancer actually relies on CT and also bone scan. But to do a CT and bone scan, especially in a private setting, you must just do a PET scan because it's much more cheaper. And PET scan actually will show all of the small minute details which actually you will miss. So if you actually look at the at the images on your left hand side, on the left hand side, you can actually see that is actually a bone scan, which looks everything is clear. But the images on the right side, you're actually finding bone metastasis in your pelvic region and also in your pubic symphysis, which is quite common for prostate cancer to spread to bones. And then lately, after Angelina Jolie did her bilateral mastectomy, removed her ovary, everyone was aware of the gene called BRCA, and then BRCA became a hit. Everyone was doing the testing, and we found out that actually prostate cancer has a high link of BRCA mutation also, BRCA1 and BRCA2, and also ATM and CHEK2 mutations. So patients who have BRCA mutations is actually more aggressive form of prostate cancer compared to people who do not have BRCA gene. And there are anti-BRCA treatment, which you call it as PARP inhibitor, which I think in Malaysia just approved about 3 years ago. So it is one of the treatment which is available at the moment, which is called targeted therapy for prostate cancer patients. Okay, so localized prostate cancer, which means very early stage prostate cancer, it has not spread out. Those days, we look at certain factors to see if the patient, we can subject them to just active surveillance where you do not need to give any treatment. But now with all the biomarker, we can actually do your BRCA test. If you're high risk, then we actually subject you to treatment. If you're low risk, then probably you just do active surveillance. Even in terms of radiotherapy techniques also, we have moved much more forward. Those days we were doing 3D conformal, IMRT, VMAT, and then now we are doing SBRT, where we actually can give a very high dose with lesser fractionation. You save time and you save cost also. And then MRI guided treatment. So nowadays we do radiotherapy with MRI guided also, because one of the main problem with doing radiotherapy or surgery to prostate cancer is actually your urinary symptoms. Most of the patients are sometimes end up with Pampers, so we can actually just use MRI to target most of the lesions, sparing all your normal tissue. Okay, so the role of SBRT is highly precise, just radiating your prostate with fewer treatment sessions. So traditionally those days radiotherapy we used to give over 7 weeks, then we came down to 4 weeks, and then now we can actually just do it in 5 fractions where you can finish it in 1.5 weeks. So there are few clinical trials like PACE-B and Hypo-RT for prostate cancer which shows equivalent oncological outcomes whether you are doing it the long fractionation or the short fractionation. And it improves your quality of life because you do not need to come to the hospital very frequent, and your gastrointestinal and gastrourinary toxicity is about similar between all the groups. And SBRT is widely available in all of the cancer centers in Malaysia. Even in KKM also is available. So to put into perspective what is SBRT, if you're actually looking at this diagram from the era of 2-dimension, 3-dimension and IMRT, your tumor size remains the same, but your normal tissue being radiated actually is reduced. So if you're talking like IMRT, SBRT, your normal tissue get very little radiation dose. And there's something new called particle therapy, like Datuk Lee Chong Wei went to Taiwan to do proton therapy. So our neighboring countries like Singapore, we have proton therapy, but in Malaysia we do not have it yet. Okay, so this is PACE-B clinical trial where they found all the localized prostate cancer patients, where they subject the patients to long fractionation, which was those days about 7 weeks, and then there's another arm which we did it in 4 weeks. So 20 fraction will take 4 weeks, 39 fraction will take roughly about 7.5 weeks, and then they compare them with SBRT, which just takes 5 fraction, which will take about 1.5 weeks. So what they found, so this is the images of radiotherapy. The one on the left is actually SBRT. The one on the right is actually IMRT VMAT. So those in color is all the radiation dose. The one which is very bright in color is a high dose, and then subsequently moving periphery is actually the lower dose. So if you're using SBRT, everything is just concentrated in the center. It doesn't cross beyond your femoral head. But if you're using something like IMRT VMAT, you get the low dose splash all over your pelvic region. So it increases your toxicity to your normal tissue compared to SBRT. So what they found in this clinical trial, when they compare conformal radiotherapy, whether you do it within 4 weeks, 7 weeks, and compare with 5 days of SBRT, your survival is the same, your toxicity, everything is about the same. There's no difference. So most of us actually has adopted to do SBRT. Okay, so in terms of surgery, I think surgery has moved more radical compared to our radiotherapy techniques. So those days they are doing open freehand surgery, which is open surgery. You have a lot of blood loss. Then you got minimally invasive, and then now we are doing a lot of robotic prostatectomy for prostate cancer patients. And maybe in the future you can have surgery by AI, where surgeons will be out of job. Maybe I also will be out of job. So let's see what happens. So robotic assisted prostatectomy is very minimally invasive. The surgeon just sits down at the side, no need to scrub in, they just play with their fingers, and then the machine will actually operate on them, where there's very little blood loss, quicker recovery, and high precision. And it is quite standard in a lot of private centers, and in government centers, I think in HKL has robotic surgery, and UPM, all has robotic surgery also. Okay, so something new I wouldn't say new, probably in the last 5 years, there's something what we call oligometastatic disease, where we don't go by stages nowadays. If you have a stage 4 prostate cancer, just one lesion in the bone, you're considered stage 4, compared to someone who's actually having 10, 20 lesions in the bone, is also called stage 4. So oligometastatic disease is defined as less than 5 metastatic lesions, where we can still try to aim to treat them radical and try to cure them. Okay, so metastasis-directed therapy using SBRT can actually delay your systemic treatment. So those days when you have stage 4, okay, straight away just go for systemic treatment, either chemo or targeted therapy. But now you can actually do metastasis-directed therapy, where you do radiotherapy, you kill off those lesions, and then after that, subsequently, when they progress later on, then you can actually go for systemic therapy. So you're delaying your chemo therapy. And nowadays, with our new targeted therapy and all, I think I haven't started chemotherapy in a prostate cancer patient in the past 3 years, because there are a lot of targeted therapies to play around. And the trials which back us up is actually STORM and ORIEL. So there are a couple of trials also, POPSTAR, and then data from MKSCC, where metastasis-directed therapy actually do delay your time to start your systemic therapy, and it does improve your survival also. So these are both of the evidence where they will give radiotherapy compared to just observation. They're doing much better with radiotherapy. Okay, in advanced disease, those days, ADT was the backbone, and some patients are still being treated with ADT. But in the 21st century, ADT alone is a crime, because there are a lot of newer treatment options, and we learn more about hormone sensitive, hormone resistant, and then whether they are non-metastatic or metastatic. So things have moved a lot in terms of advanced disease also. So those days we used to give docetaxel, which is an IV chemotherapy, where you get a lot of hair loss, you get numbness, you get a lot of body aches and all. But nowadays we have a lot of novel anti-androgen therapy, hormonal therapy like apalutamide, enzalutamide, and also abiraterone, where it's just an oral therapy. You take it daily, and you can actually delay your chance to start your systemic therapy later, which is your chemo. So these are all the FDA approved drugs from 2000 to 2020. As you can see, there are many options of treatment available for a patient these days in prostate cancer. Okay, and in castrate resistant, once when you've already failed your first line treatment, where you're already castrate resistant, which means your testosterone level is actually very low. So there's this study from US which shows that patients who are BRCA positive, they can actually go for PARP inhibitor, which is another form of oral therapy also. They just take it twice a day. And then even moving forward nowadays, we have PSMA ligand therapy. So PSMA PET, we use like lutetium therapy. The radioligand is lutetium. Those are for diagnostic. But a higher dose is called a therapeutic radioligand therapy. So for some patients nowadays, even like first line castrate resistant, sometimes we straight away just go for radioligand also, because we have studies to support to use radioligand as first line or second line or third line. But radioligand therapy is very expensive. Your whole cost of radioligand therapy can go up to 120,000. So most patients can't afford that, so we just play around with the androgen receptor blockage like the targeted therapy oral. Okay, so lutetium PSMA therapy is a radioligand therapy which targets your PSMA receptors. There are two trials, actually, one is Vision and one more is PSMA-4. So both of the trials support to use it pre-chemo and also post-chemo. And it is approved in Europe, and radioligand therapy is available in selected centers in Malaysia. Even in government also there is availability in IKN. So this is just a diagram where in prostate cancer cells, you have these PSMA receptors. So when you do the radionuclide, the ligand will actually grab it, go inside, and then it will shoot a gamma ray out so that your applicator outside can catch the images of the gamma rays. So this is actually to see a diagnostic image of your prostate cancer. But when you give at a higher dose, the same principle occurs, but the gamma rays will actually kill off your cancer cells, which cause cell death. Immunotherapy in prostate cancer is very, very behind compared to most of the other cancers. I would say majority of cancers you can use immunotherapy, but unfortunately in prostate cancer, immunotherapy didn't show much benefit unless if you have a marker called MSI high, which is actually very, very low for them to have in prostate cancer also. So there are a lot of clinical trials to do with immunotherapy, and they're trying to combine with other drugs like targeted therapy to see whether they get benefit or not. Okay, so future directions of therapy. Lutetium is widely available, so now they are moving forward to actinium therapy. It is a alpha emitter. Lutetium is actually a gamma emitter. So actinium is something newer, which is not available much in many centers yet. It is more potent, and there are a lot of clinical trials which is being done to see whether it can supersede lutetium therapy or not. And then there are also iodine therapy, yttrium-90, which is already available, which we're using for different cancer indications like thyroid cancer or liver cancer. But they're doing clinical trials to see whether prostate cancer can actually work with them or not. Terbium therapy is something new also. Not much data available at the moment yet, but something to look for. And then maybe in the future, AI can help us a little bit. And pathology is very important. So for us nowadays in oncology, we need a biopsy to determine what is the best treatment for you. So once we know your biopsy, we know what mutations you have, and then what mutations you have, they can actually check and see what drugs can target those mutations better. So those days we use tissue biopsy, but nowadays we can just do a blood biopsy. So technology have moved so much in the past couple of years. So there are a lot of exciting things which will happen later on. So blood biopsy is called liquid biopsy. So you just take a blood, you send it to the lab, you can check all the mutations. It takes a longer time compared to tissue to get the report. So as a summary, there's major strides in prostate cancer management over the past decade. And imaging such as PSMA PET, multiparametric MRI actually helps us in a lot of cases these days. Molecular profiling can actually target those treatments. If you're BRCA or you have any special mutation, you can actually use those drugs to target. And the chances of someone to actually have a mutation in prostate cancer, if you're not talking those standard mutations like BRCA and all, is about less than 5%. So there's still some hope if you have failed multiple lines of therapy. And surgery and radiotherapy are becoming more precise and patient-friendly, such as SBRT and robotic surgery, where your toxicity is much more lower. Newer systemic therapy like novel oral therapy like apalutamide, abiraterone, enzalutamide, PARP inhibitors like olaparib, rucaparib are all available in Malaysia these days, so you can actually use either one of them. And radioligands, so far, there are options of radium and lutetium. We have lutetium in Malaysia, we do not have radium, if I'm not mistaken. It do improve your quality of life and improve your overall survival also. And everything above else, always we discuss our cases in multidisciplinary meeting. It's very important for a cancer patient to be treated by multidiscipline rather than just one doctor, because everybody will have a different idea and then we can come up with a plan for a patient. And personalized treatment is the way to go for cancer patients these days, using your own genomic profiling, where you need your blood test or your tissue to find out what is suitable for you. And metastasis-directed therapy in localized or oligometastatic disease is the way to go also, because in Malaysia we are all clinical oncologists where we give our systemic therapy and we give radiotherapy. So combination of both treatment actually improves your outcome compared to just doing a single treatment. Okay. Thank you. That is my presentation.